Hi and welcome to Synapse. This is Dr. Sonika. Welcome to the third video of the MRCS series. Today we're going to be talking about the MRCS Part B examination. So congratulations for those who have cleared Part A exam and who are here to plan and prepare for their Part B. Kudos, good job. And those who are new here, I'm Dr. Sonika. I'm a senior resident and a trainee in plastic and reconstructive surgery in India, and I have cleared my MRCS exam in the year 2023. So this video series is just sharing my experience and helping those medicos who are appearing for the exam and to help them with the tips and tricks that really helped me during my journey. Uh, with that, let me just highlight one of the things that I did not during my previous two videos. So you guys know that the first video was about the myths associated with the MRCS exam. We have busted a lot of myths, and the second video was about the Part A examination, everything about the syllabus, how to prepare, how to plan, and really how to tackle the examination. So kindly go ahead and watch those if you haven't yet. And with that said and done, so the thing that I want to mention here is the maximum number of attempts. So the Part A examination, the maximum number of attempts are six, and for Part B it is four, which I did not mention in any of the previous videos. And actually, there's a clause for additional attempts also, but I'm not very sure. There are a number of scenarios where you can apply for it and you could directly get in touch with the Royal College. I have not seen anyone who has done it in the past. I've not spoken to anyone who has gone through that pathway, so I'm not the right person to talk about it. But I think six attempts for Part A and four attempts for Part B is good enough. Most of them clear these these parts in the given attempt. And the maximum duration between the Part A and Part B examination is 7 years, right? So the gap between your Part A and the time you appear for Part B should not be more than 7 years. So this is one thing I wanted to highlight right before getting into the video proper. So with that said and done, let us move on to our Part B discussion. So the Part B examination is an OSCE-based examination, which is a totally viva kind of a situation where you have a number of stations. So the whole examination is divided into two different categories. So the first category is the clinical knowledge component, which checks your knowledge, right? So that will include your anatomy stations, the pathology stations, and the clinical critical care situations. Okay, so these are the stations which are included in the clinical knowledge. And the skills is the other set. So the skill stations will include your history taking, examination, communication skills, and the procedural skills. Okay, so we will look into these stations in more detail. So typically, an OSCE examination will have around 17 to 18 stations. And I will again give you the distribution as to how many number of stations is allotted for separate topics which I just mentioned, like how many stations for skills, how many stations for knowledge. We will go through that in more detail. So overall, I'm just giving an overall picture before we dive into more details of the exam. Uh, so there are around 17 to 18 stations, and there are certain rest stations also included. The number of rest stations depends upon the number of students that are going to appear for the exam in from that particular center. So if there are 18 stations and there are like 20 students, you will have two rest stations because every student should have an allotted station at any given point of time. Right, so if there are actually 18 stations, the other two students will be having rest stations. So it just goes in a form of a circuit, and then every 10 minutes you move on to the next station. So I appeared for the MRCS Part B examination from the Royal College of Edinburgh. I gave from Delhi, and I was in Delhi at that point of time. I gave it in March 2023. So the way the exam was conducted here, I'm going to be talking based on that. And I have certain friends who have appeared for this examination even from the UK. So I'm going to take the experience and the kind of uh, uh, pattern that they were exposed to and how exactly they're prepared. So it is a collection of information from all those who have appeared for the examination in the recent past, right? So you're going to get all of that those information that will be useful, right? So that's that. We have spoken about the total number of stations, how exactly or broadly it is divided, and I said the eligibility criteria is just that you should have passed your Part A examination, and you have to book your Part B exam. You just have to look online, look for the dates and the center which is close by. And what problem with the Part B exam is that the dates get filled really fast. Okay, so if I have seen that, okay, there is this Kerala that open for the Part B examination in India. You say today, within 2 days, it's completely booked. Okay, so the number of people who are writing Part B examination that are international is extremely high, right? So the moment you see a date, if you're from India, I would suggest go ahead and book it. It could be from any part of India, okay? Whether it's Delhi or it's Kerala or Chennai, whatever center is open, just go book it, okay? So that's that. Otherwise, you'll have to wait because another next 6 months only then you'll have the dates available. And you'll be just wasting your time. I don't think you should be doing that. And right, so you book your exam and you have chosen your center. Okay, let's talk about the day of the examination. So you'll have to just carry your an admit card. It's not an admit card, it's just an acknowledgement that your Part B examination has been booked. You're so and so candidate. This is your examination center. You would have got it via email. You can just print it out or have it on your phone and you take that to the exam center and your passport. So these are the two important things that you need to carry. And I gave my exam through RCS Edinburgh, as I have mentioned. Uh, in my center, what they did is they divided our group into the total number of students into two groups. So there was one circuit for skills and another circuit for knowledge happening simultaneously, right? So we would finish one circuit. Then the two groups would exchange, and the people who did skills would now go to knowledge, and the people who did knowledge will go to skills, right? And we had a break of 15 to 20 minutes in between before the actual exchange. But there are some centers who don't follow this circuit pattern. It's just that it's random. So you can, if you have a skill station, your next station could be a knowledge station as well. Okay, ultimately, it's the same thing. Okay, so either you could have a separate circuits running simultaneously, or you could be having all the students go through the um, skills and knowledge station in a mixed pattern. So there is no actual segregation as such. So I'm why I'm saying telling all these things is that as a student who's appearing for the exam, you should know all the scenarios. Okay, there's nothing great in this. It's just that it shouldn't come as a surprise to you on the day of the examination. Whatever it is, the uh, pattern you will know, and it's just that you shouldn't get worried. Okay, it's the same thing. And every station is for 10 minutes. So initially you will get 1 minute to read the question stem. Okay, so the way it is conducted is that every student, so there is one student allotted per station, and you stand outside the station, and there is a paper stuck on the door or the wall of the station before you go inside. So on that paper, they would have written the scenario and what exactly you'll have to do in that station. So you get 1 minute to read the scenario and to get an orientation as to what you're going to. Okay, so if it is, let's say, anatomy station, it would just say that, okay, this is the clinical knowledge station, the anatomy station, where your knowledge will be checked regarding, let's say, the lower limb anatomy or upper limb anatomy. Okay, so that's all you will see for an anatomy station. If it is examination station, they will say, okay, there's so and so male patient, age so many years, has come with the complaints of pain in his right knee. Kindly examine the patient and go ahead with the questions that is asked during the examination station. So that's all. So you get 1 minute to read this question. Okay, you don't need 1 minute to read it completely. What it actually means is you read the question stem and you formulate you revise the pattern in which you're going to approach the station in your mind. Okay, so the first 10 to 20 seconds you're going to read and you'll understand what the station is about. In the next 30 to 40 seconds in your mind, you need to be thinking and you must have a list of questions you're going to ask the patient. If it was, let's say, I said examination, so in your mind you should have the pro forma for the examination of knee. So you should be like, okay, I'll ask this question first, next, okay, inspection, this is palpation, I'll do this, and then for auscultation to do that, and these are the special tests that I want to do. So that is the kind of preparation that is required when you're standing outside the station while reading the stem. Now, there will be a bell that rings at the end of 1 minute. That means now it is time for you to enter the station, right? So you enter the station. So whatever be the task that is mentioned there, you will do the task. Now, for history station, examination station, okay, you will and let us say the uh, critical care station. So you get only 6 minutes to do your to perform the task that is given. Like if it is examination or history taking, you get 6 minutes to interact with the patient. Most probably the patient, the people who come as patients are actors. Okay, but there are certain scenarios where you can have a real patient come also, because I'll tell you later on in how my exam was. So wherein my vascular station, examination station, there was a real patient with vascular claudication. He did not have ATA PTA pulsations palpable. So I had to come to the diagnosis that it is vascular claudication, calculate the ABPI, and later Viva they asked a lot of questions related to it. So you can have a real patient versus you can also have actors. So actors who come with complaints of uh, pain in the knee, pain in the back. So you'll have to do examination, okay, of these patients. It might essentially be normal, but you have to do examination on these patients. So that's that. So you'll get 6 minutes to perform this, and the next 3 minutes. So we have spent 1 minute outside, 6 minutes inside. So we have 3 more minutes to complete the station. So in those 3 minutes, the examiner is going to ask you certain questions, okay, pertaining to that scenario or whatever you've done in the station, the examination. So you get marks according to that. Okay, so like this, we are going to move ahead. And for anatomy station and basically the knowledge stations like an anatomy and physiology, and for your communication station, you get complete 9 minutes to answer to the examiner's question, because there is no patient. So anatomy station, you go in and directly you start getting questions on anatomy of whatever part that you've got. Let's say lower limb, then you direct your question start with, let's say you got foot, and they'll start questions regarding foot. If this pathology, you'll start getting questions regarding, let's say, rheumatic heart disease, you get questions regarding that. And if it is communication, there is a patient's relative or the patient himself sitting there. So you start getting, you have to start talking to the patient and address the concerns, and you'll start off. There is no viva component in that. So they will give you marks based on how you communicate with. Again, we'll see how exactly the marks breakdown happens for these stations. Okay, so I'm just telling you about the time component. See, the Part B examination, the pass rate of Part B examination is way higher than Part A exam. Okay, it's not difficult to pass Part B, but the point is you're doing the same history taking, you're doing the same examination. Okay, you're explaining what you normally do for the patients in your hospital. You've done the same thing during your internship, your MBBS, your PG, whatever it is. You've seen all these patients. Okay, you know how to examine neck swelling, you know how to examine a thyroid patient, right? You know how to take the history. You've done this day in, day out. But the point is, you need to do that in a more systematic manner within the given period of time, that is 6 minutes. You have to take all the history. Okay, if it is examination, do all the examination without missing any point, and be able to summarize what you're doing, what you've done at the end of 6 minutes. So that is what is going to carry marks in the examination. So part B is all about practice and practice. Okay, it's not difficult at all. Okay, that's what you do on a daily basis. It's just that you have to be more practiced and more organized to clear this exam. Okay, so that's the overall pattern of the exam. Now let us look at the individual stations. Okay. Okay, so now let us look at the stations in detail. So the Part B stations are majorly divided into two categories. One is the clinical knowledge station, the other one is the clinical skill station. So in knowledge, we have three stations in anatomy, two on pathology, three on critical care. And in skills, we have two on history taking, three on examination, two on procedural skills, and two on communication. Now I have made these in different colors so that it is easier for you to kind of remember that these what comes under skills, what comes under knowledge, and also to differentiate and to practice in a different way for these stations because the scoring pattern is different. Okay, which we will see in a while. So right, so talking about the anatomy stations. So we have three anatomy stations, out of which one will most probably be on the limbs. Okay, it can be upper limb or lower limb, right? And the next station will be on either abdomen or thorax, and the third station is going to be on head and neck. This is the routine usual pattern. Okay, and for the anatomy station, okay, you're going to have images, okay, of prosections. Okay, that means, so you in your first year you've done dissections, you have identified structure on the cadaver, so they're going to take pictures of the cadaveric sections and they can point to any one structure and say identify the structure. Okay, so for, or it could also be picture from any atlas. Okay, they might, if they don't have cross-section picture, they might take a picture from an atlas of a particular dissection certain plane, and they can ask what exact structure that they're pointing to. Okay, so this is the kind of examination pattern that is used for the anatomy, right? So if you have studied anatomy in a theoretical manner, now it is time to do the revision and to study with the help of images, prosections, and atlas. Okay, so what you do is I will provide the free resources that I found on the internet for the Part B examination. Honestly, that's all I used with in a hands-on course. I'll talk about these in the resource and the materials that you're going to use for the Part B exam. But I'm just saying that I will leave the link, either the link or the document itself in the description box. You can open and download and use these free materials. Honestly, to speak for me, I had to, like search the internet for a bit and then I found all of these materials for free. Okay, so in that you will go through the material. So in which they would have given, a station on, let's say, the foramen of the skull, or stations, anatomy station on the foot or the upper limb, the brachial plexus. So all these topics are to be studied with the help of pictures, diagrams. Okay, so all that you do is in this material, and as well as any material that you take for Part B examination, that too, especially the knowledge section, will come with pictures and the kind of questions that come in the in your examination. So all you do is you're going to close the labelings, okay, and start identifying these structures one by one. Okay, so that you know what exactly you're seeing in that particular picture. Okay, so that is how you need to go ahead with the preparation for anatomy. And so I just mentioned the three stations, right? So one was on limbs, the other one could be thorax or abdomen, and the third one is going to be on the head and neck region. So you got to get your anatomy really, really clear. Okay, and these are scoring stations. Okay, here you don't have any patient. You are not judged, or you're not going to get marks based on your communication or your professionalism. Nothing doing. Okay, you go in, you get questions, direct answers, and that's it, score marks. Okay, so let me just walk you through how the anatomy station goes. So outside you read this you know the question stem saying, okay, your anatomy station is going to be on this topic, okay, for 1 minute. Okay, then it's done, you go inside, the bell rings, you go inside, and there is examiner. So examiner starts, he shows you a picture, he starts pointing at things and starts saying, okay, identify this, that. Okay, so usually the knowledge station will have somewhere around 10 to 12 questions on an average. It could be more or less, and you will start answering his questions. And in this, you have 9 minutes to go through all the questions, right? And here you have to be directed and you have to give very clear cut answers. Okay, if they say identify the structures, you directly say, if that is carotid artery, you just say this is the external carotid artery, or if it's internal, just say internal carotid artery. You will not say, I think this must be, I think so, nothing doing. Okay, directed one word, or how like try to give the precise answer to the question that the examiner has asked. Okay, and let's say you don't know answer to a particular question, and you think you need to think or rather remember something in order to answer it. You can say, I want to pass the question. Okay, you can come back to that at the end of you seeing all or hearing all other questions. Okay, you can tell the examiner, okay, I would like to pass this question and come back to it at the end of the station. Most of the examiners oblige, and they're like, right, okay, so they go on to the next question. So within 9 minutes you go through all the questions, answer everything that you know, and there might be one or two questions you don't know, and then you tell the examiner that I would now want to take up the questions that I had passed. Okay, and the examiner is more than happy to let you come back to those questions. Some people do it on their own, so they themselves will ask you saying, do you want to take those questions? There might be some who do not. So in such situations, you directly tell them that, okay, can you please go to the questions that I did not answer, the questions that I had passed. Okay, so that's how you score. Okay, these are all scoring stations, right? So knowledge station. That's how the anatomy station goes. And then pathology, again, there is the material I just mentioned, just go through those stations. The material that is given, that is all that you need for pathology. You don't have to read one extra thing for the exam. Okay. So for surgeons, pathology, we do not take them that seriously. So the material that you get, that's all you need to read, nothing more than that. Okay, so don't worry about pathology. So that is also very similar to anatomy. You go and you get straight questions, answer all of that. You can pass and you can take those questions and try to answer as many as possible. Try to be very precise and direct answers. That's all. And critical care station. In critical care, usually it is going to test your knowledge on, basically it's applied surgical information. So they might give you scenario like, okay, you've seen one patient who is met with RTA, and your the vitals are so and so, the patient is calm. Now what do you do? So all they want to hear, for, see, for trauma cases and everything, critical care trauma, just say ABCDE. Okay, so any critical patient, you just end up saying, I will do ABCDE. Then they'll ask, okay, how do you proceed with A, or how do you proceed with B, C? Yeah, like that. And how do you identify that it is a C crisp or a critical care patient? Okay, so C crisp stands for care of critically ill surgical patients. C crisp. Okay, so usually it is going to be a post-operative patient, and there will be no problems with the, there will be no problems beforehand, and there is an acute complaint that or an acute symptom that occurs, which brings you to the ward or something like that. So that will be the setup, okay, in the history. And and the patient will be kind of unstable, and when you start examining, the patient will have so much pain or something, he becomes non-cooperative. So these are all the hints that tells you that this is a critical care station, and you have to go back to your basic, that is ABCDE. Okay, that is how you start. So you know how to check for airway, breathing, and while you do that, make sure that pulse ox is connected. Then you will check that his, you're going to look at his circulation, take his pulse. While doing C, then you look at the BP, then you will look at the deformity, if any. Then in exposure, make sure you do two things. Okay, exposure, if it is a post operative patient, look at the incision site. Okay, if it is abdominal laparotomy patient, open the dressing, say I'm going to open the dressing and look at the incision of the patient. Okay, and to see if there is any discharge or any kind of SSI kind of a situation, or a leak, whatever it could be, right? So that is one point. And the second point is, you're going to expose and see the calf. Look at the calf tenderness for any kind of DVT. Okay, so these are the two things in exposure that you're going to see, that is going to fetch your marks. Okay, so critical station is all about practicing C-crisp. It's the format, again, you're going to go in step one, step two, step three. So all of this will be given in your hands-on course. You will get to know these steps, and you're going to practice this again and again, so that it becomes a reflex for you to go in that particular order and examine the patient. Okay, so critical care also, you get okay, let's say you have examined the patient, then you will get questions by the examiner at the end of your 6 minutes, he's going to ask questions regarding, okay, what do you think is a diagnosis? Or he might give you a CT scan. If it's trauma patient, he's going to show you a CT scan, let's say ruptured liver or ruptured spleen, and he asks, okay, how do you identify this? What do you think it is? Okay, then what kind of extra care are you going to take for the patient? What kind of management is going to be necessary for this patient? Or if any complications, he's going to ask questions on that. So that is your applied surgical concepts or critical care stations for you. Okay, so if I would say among all these, I think you should give among the knowledge stations, you need to give a lot of stress onto the critical care station, and following that, your anatomy and pathology. So that needs more practice. Okay, and now let us move on to the skill stations. Okay, so the first one is about the history taking. So history taking, here usually you're going to have an actor. So it could be history of, plain abdomen, bleeding rectum, or it could be hemoptysis, or patient with knee pain. It could be anything. Okay, again, the notes will be given. Just go through all the scenarios that is given in the notes. So you know the kind of questions you need to ask here again will be given in the notes, and you've done it in your clinical postings also. So it's just about organizing those questions and trying to arrive at a diagnosis. Okay. So just let me tell you, in this kind of exam, now, there is going to be very simple. You're going to get 4 marks straight. Okay. First is for saying hello and introducing yourself and asking for the patient's name, confirming his name and age, and asking him what brings you to the hospital today or how are you doing today. Right. So, hello, good morning. I'm so and so doctor, one of the doctors, one of the doctor in the team of, the so and so hospital doctors who is looking after you. And may I confirm your name and may I know your age? What brings you to the hospital here? Whatever. Okay. So that brings you 1 mark. And let's say at the end of the station, you say thank you. Okay. If it was a examination station, you after examination or doing a procedure, you dress the patient and you say thank you, you get another mark. You get marks for sanitizing your hand, okay, before you start examining the patient. Yes, you get marks. So this is how the part B exam, this is how you're going to score in your skill section. Okay, there are certain habits or the procedures that is kind of mandatory. Okay, if you remember it, you just do it to every patient, and you just get 3 to 4 marks just like that. Okay, and usually the patient has a band on his wrist, so you get 1 mark for confirming the name that the patient says and just checking that the wristband saying okay whether it's the same patient or not. And patients, sometimes the patient might have a red band on his wrist or his arm. So red band signifies allergies. Okay, that the patient is allergic to something. Okay, if you see the red band, if you note, okay, I see you have a red band. What are you allergic to? So if you just identify that, you get another 1 mark. So you already have 4 or 5 marks in your pocket, even without doing the examination yet, or without even taking the history yet. So that's how you score marks in the clinical skill station. Okay, so that was about the extra, how to get the tips and tricks to get extra marks. So in history taking, again, as I said, you read the stem, you go inside, you find an actor, you get 6 minutes. So you start taking the history, try to ask leading questions, and also you should listen to what the patient is saying. So when the patient or the actor says something, you say, oh right, okay, you have to acknowledge what he's saying. You have to be empathetic. Sometimes they might say like, okay, you know what, this is so distressing, I don't this is what is my problem, this is what is uncomfortable for me. Then you say, oh right, I understand. Okay, this is the problem. Okay, right. So you got to acknowledge what the patient is saying. You cannot just be like, okay, I asked one question, next, okay, now where does it hurt? He says, okay, here. Then you say, what kind of pain? So you cannot ask such questions. So it should be a nice conversation that you're going to have with the patient. And for this history taking station, there's going to be an examiner who's going to see how you take the history, the accurateness of your scientific knowledge, and there is going to be a layman who's going to see how you interact with the patient. Okay, to see how empathetic you are towards the patient, what is your behavior like. And there's going to be an examiner who is going to be checking your language. Okay, so there are three people in this room, in the station, so they keep doing whatever they have to do. Only the examiner, the person who is testing you on your clinical knowledge, or the basically the accurateness of your clinical information, is the one who's going to ask you questions at the end of the history taking or the examination. So at the end of it, you should be able to summarize what the patient has told you, okay, including the important positive history, as well as if there is any significant negative history, you can add and you can uh, tell it to the examiner. So then in usually the history taking section, you get marks for summarizing. Then he's going to ask you question based on how did you arrive at the diagnosis, what are the points in your history that favored your diagnosis, how are you going to image the patient, or what are the other investigations you would want to do in this patient to confirm your diagnosis, and what will be your management. So that is how the station usually proceeds. And for examination as well, again, you read the same stem outside, you go in, okay, now you know the routine, how to get 4 to 5 marks. Okay, so simply you say hello, introduce, ask the patient for his name, his age, look at the tag, look if he's having any red tags, as in bands, and then you start when you before you start doing the examination, you see if you're a male candidate and if the patient is female, you go to make her feel comfortable. You have to say, okay, do you want a chaperone in the room before I start examining? So if she says yes, then you just tell to the examiner that yes, I would like to have a female nurse or a chaperone in the room before I start my examination. Okay, and before you start your examination, you've got to get the verbal consent from the patient. You've got to explain them, okay, see, okay, you said that you have pain in your right knee, so today I'm going to examine your right knee. Okay, it involves looking at the knee, touching the knee, and doing certain, maneuvers and moving your knee. Okay, if it hurts, so do let me know. If it is beyond your capacity to bear the pain, if it's too uncomfortable, let me know. I'll stop at any point of time. Okay, so that is how you make the patient comfortable. Tell them what exactly you're going to do, and then you start your examination. Okay, and at every step you keep telling them, okay, now I will stretch your leg. Okay, let me know if it is painful. Okay, after you've done that, now I'm going to feel your skin to look for any warmth in the skin. Okay, so that is how you're going to communicate with the patient while you're doing your examination. Again, the catch here is that you go to finish your examination in 6 minutes. Okay, you do not have the whole day. So examination, practicing these examination stations is extremely important so that you do not forget the points that you're going to see. So in palpation, you should like quickly know what all things you're going to do. In inspection, you should know quickly what all things you're going to do. Okay, that you will revise while you're standing outside the station. You come inside, you take the verbal consent of the patient, make the patient feel comfortable. After explaining what exactly you're doing, you go ahead with the examination. Okay, and you have to remember all the steps and do it in the correct order. And even if you forget, let's say you forgot checking the pulsations, you've already come to the end of the examination, you can just tell the examiner that I would want to look at the pulsations of blah blah vessels of the peripheral limb. So you can do that. Okay, so that is if you forget. So you should not worry saying, okay, I forgot vascular examination now. My whole the order in which I have remembered how to perform the station will be messed. Okay, you should not mess up the rest of the station just because you forgot one point. It's totally fine. You can say, I forgot to do this. I would want to go ahead and go back to the patient and do this examination or whatever it is. Okay, at any point of time, you can go back and you can say that. Okay, so you don't have to worry about forgetting some point in examination or in history. Okay, and right. So you have done the examination and you are supposed to summarize it at the end of 6 minutes. And then again, they're going to ask you questions. As I said, in history taking, that's going to be about how do you arrive at the diagnosis, how do you investigate, and how do you work up the patient, and what is going to be a definitive treatment. And before you start examining a patient, always make sure you use a hand sanitizer. Okay, if there is a basin, you just say you're going to wash your hands. Like, it's better if you do, but usually that's going to take some time. The examiner says, assume you've done it, or otherwise, if there's a hand sanitizer on the table, just use it before your examination. And then coming to the procedural skills, there are number of stations that can appear here. So there are two, right? So it could be like catheterization, it could be ICD insertion, it could be suturing, it could be not throwing, it could be making, your organizing your OT list for, or rather planning your operation theater list. So these are all the skills that are included under this. So when it comes to the procedural skills, this you will get an exposure as to how to approach this and to do this during your hands-on course. I would say that's the best time to do it and to learn the procedural skills. And this does not involve anything great. See, for example, as I just mentioned, doing catheterization, doing suturing, all of these are very, very simple things that you've done it during your MBBS. Basically, you've done during your internship, okay? And you must have seen during your final year MBBS. From right that time, you've seen so many procedures. You might have done many of them as well. It's not a big deal. But the thing is, again, you have to do it in a methodical, sterile manner. Okay, that is for example, let me tell about the catheterization. Okay, so come on, do the drill with me. Okay, so you're standing outside, you read it on the sun stem saying, okay, there's a patient with whatever having difficulty with passing urine, and so now you have to catheterize the patient. Okay, so now you know it's a procedural station, and my job to do what I have to do is catheterization. Okay, 1 minute is done, the bell rings, you come inside, you see the patient. Usually it's going to be a mannequin. Okay, for all these procedural skills, it's going to be on a mannequin. So assume that there is some patient there and you have to talk, right? So even if the mannequin, you just say, okay, hello, I'm so and so. May I know your name? May I know your age? Okay, right. So today, I hear that you have some issue with passing of the urine, and I'm here today to pass the rubber catheter through your waterways so that we can drain the urine and alleviate your discomfort. Is that right? Is that okay? And then so you're going to explain all the procedure that you're going to do, in simple layman terms. And this is very important. You cannot use medical terminologies. Okay, so again here you're going to have the examiner other than the technical one, the basically the language and the layman examiner who's going to check how empathetic you are, how exactly you perform in your language, right? There is a person who is looking at that, and here you cannot tell or use the medical terms. Okay, so you just say waterways instead of saying your urinary tract. Instead of saying catheter, you just say a rubber tube. Okay, in a way that the patient understands. So after you explain it to him, and then you have to verbalize and you have to say, I'm going to take consent, and then I'll take written consent and then proceed with the procedure. Okay, so assuming it is done, and then you'll ask, okay, you're comfortable, you can just lie down. Again, you'll explain that if there is any trouble or pain, that's something that makes you uncomfortable, you can stop me at any point of time. And Okay, we'll make sure that you're comfortable. Okay, to just assure it to him multiple number of times that we're not going to harm you. Okay, so once that is done, for this station especially, you got to actually make a trolley also for yourself. There's going to be one person other than the examiner who's going to be like a nurse or a helper who will ask whenever you ask things like, okay, can you open the catheter for me, can you open the urosac bag for me. They are the ones who are doing that for you. Okay, so you can ask them. Now you'll have to set the trolley. You got to have all the instruments. They would have kept it on a rack or something. You got to take it and arrange it in an order that you want for the procedure. Okay, in a sterile manner, you wear gloves. You keep your catheter. If you want, you just ask the nurse to open it. Okay, that you keep. You ask for a sterile syringe loaded with the lignocaine. Keep your distal water for the inflation of the bulb. Then you keep your gauze pieces, right? So to clean with the betadine, and you're going to keep your sterile drape. So all of this you're going to assemble first, and then you go to the patient. Okay, then you start doing the procedure. So in this procedure, very important, you got to wear double glove. Okay, so you wear two gloves. So you're going to paint the area, then change your glove, use a sterile drape. Okay, drape the area, then keep a kidney tray underneath the penile area so that whatever urine, if at all there's a leak, it gets collected, does not soil the clothes or the your drape. Okay, so you keep the kidney tray, and then you are going to inject the lignocaine and close the urethral meatus and tell the examiner that, okay, you don't tell the examiner, you just verbalize what you're doing, and you say that, okay, now I'm going to wait for a few seconds for the lignocaine action to appear. So what I'm saying is, every step when you're doing, you just verbalize what you're telling. It's not that you're telling to the patient, okay? You are telling it, you're vocalizing, verbalizing whatever you're doing, so that the examiner knows what you're doing, right? So that is the purpose. But you are not going to look at the examiner during the 6 minutes while you're performing the procedure. You are not looking at the examiner at any given point of time during the procedural skill part. Okay, when you're performing it, you just vocalize. Okay, now I have injected lignocaine. Now I'm going to keep the meatus closed for the next 1 minute or so until the action of the lignocaine comes. Okay, now it's then he will say assume time, because you cannot stand for 1 minute, right? You cannot waste that amount of time. He says assume time. Then you will proceed. You're saying, okay, now I'm taking the Foley's catheter 14 French, and I'm going to pass it slowly up the urinary tract. And then you just look at the patient and you say, now I'm going to pass the rubber tube. It might feel a little uncomfortable. Please bear with me. If it's if you cannot bear it, then let me know. I'll stop the procedure. So when patient says yes, go ahead, then you start passing the catheter, and then you go to the Y junction, and then you have to connect the urosac back. You have to confirm that the urine comes before inflating. This is very important. Okay, once if the urine is not coming, you do the aspiration method. The urine comes. Okay, then you connect the bag, and then you inflate, and then you fix the tube. Okay, so let us say sometimes it so happens that urine might not come also. Okay, there are stations where people have faced this where the urine does not come. Okay, then again you go to the Y junction, you inflate, and you come out, and you let it be, give suprapubic pressure, and the rest of the discussion will be happening during the next 3 minutes. So once that is done, and after that, you have to, once the catheter is put, you have to dress the patient again. You got to clean the area again, remove all that drape and everything in this card, re-drape, I mean, matlab, dress the patient again and say thank you, okay, for cooperating. And then you will say, now I'm going to discard all the things that I have used for the procedure, and that's how you end the station. Okay. So the critical takeaway point here is you verbalize everything you do, know the order in which you're going to do your station. The steps that they have to be in the same order. Okay, so I just said in history and examination, even if you forget something, you can come back, you can tell the examiner, right, I forgot this, I would want to do this examination, or I would want to ask this point from the patient. But in procedure skill, there's nothing, there's no coming back. Okay, so you've got to get your order right. And again, in this, you're going to get marks for communication and for your professionalism. So apart from catheterization, I just said there could be ICD insertion, there could be nevus excision, suturing, and there will be also knotting. So in the knotting part, there's going to be like a device. Basically, it's like a cup. Okay, and there is going to be a hook at the bottom of the cup. Okay, which is basically attached by a magnet. So you'll have to throw a knot or on that hook. Okay, so you have to try to do that. Basically, it's at the bottom of the cup, right? So it's going to be a deep knot. So basically, they're trying to simulate a bleeding vessel, let's say deep down in the abdomen or some kind of cavity. So they're going to check how well you're able to, knot it and secure the vessel. So if you put more pressure, then the magnet just detaches. So that means your vessel is out, and it is not a great suture, matlab, knotting technique. And apart from that, they could ask you to suture. So these are all the kind of stations that come in procedural skills. All of this will be covered in your hands-on station, hands-on examination or whatever course that you're going to take. So do not worry about procedural skills, that you will do only at the time of your hands-on course. Rest of it, you got to be prepared, and you have to be, doing your revision during the hands-on course. So that's about procedural skills. And after, let's say you have finished your procedural skill, there'll be some questions on Viva, like for the Viva part, like if you've got knotting and sutures, they'll ask you regarding what are the suture materials, what is absorbable, what is not absorbable, what are the examples, and what are the advantages, when are you going to remove the sutures, and all those things. Okay, and communication. So in communication, we are having two stations. So one is going to be a phone call station that pretty much remains standard, and the other one is going to be talking to a patient or a patient attender. So which could include like you're talking to. I'll just give you my example. So in my exam, I had got the station where a child has fallen while playing at the park and is sustained splenic laceration, rather splenic hematoma, and he is taken up for surgery, and he was brought to the hospital by his father, and his mother was not informed. So now she comes in barging saying, how dare you take the patient, how dare you take my child for the surgery without informing me. And by the way, the husband wife are separated, so she's frustrated. She's like, first of all, it's my son, and my husband has been irresponsible, he's sustained injury, and you're taken for surgery without informing me. So you have to calm her down in 9 minutes. So 1 minute you read the station, you get time to read the stem outside, and then you go inside. You will face the lady for the next 9 minutes. So you can get situations where it could be a patient whose CT scan has been, cancelled because the machine is not working. Situations like this, or there's a patient whose OT is not possible because his endoscopy appointment is not possible because the surgeon is busy with the person who's supposed to do is kind of the senior consultant is busy with another emergency case. So in these scenarios, you got to talk with the patient and the attenders, and you have to calm them down, saying, okay, this is the situation, we will try to arrange an earliest date possible, or redate you for the endoscopy or the CT scan or whatever may be. So these situations again require a lot of practice, and you've got to keep your calm. You've got to be empathetic with what the patient or the attender is saying to you. And these are actors, okay, mind you, they're very good. So they can scream at you, they'll start crying, they'll start doing all this extra drama, and but you got to keep your calm. You should not get up. Okay, you should not show that you are being intimidated by them, or you should not get angry. You should not raise your voice. Okay, you got to remain calm. So you got to be dignified. At the same time, you got to also understand what they're saying and be empathetic towards what they're saying, and give a logical solution to their issue or the problem. Okay, so in this spleen station, then after calming her down, usually it takes some time, and then after calming her down, she takes some time, and she calms down, and she starts asking me, okay, okay, this is the surgery you've done. Now, what all things should I take care of my son during the post-operative period? Then she'll ask about, okay, how often do I come and visit? Is there a problem? Okay. Um, You've removed spleen, you've removed one organ only from my child. Will that affect the life of the child? So, the normal questions that we usually counsel our patients regarding all that. And then you will have to talk about the vaccination also. Okay, so all these things you should have read, okay, before going to the exam. So you got to talk about all the pneumococcal, all those vaccines that you're going to give, meningococcal vaccines. You should just explain her that so and so is the vaccination schedule that we have to follow, and with that we'll have your child immunized for all the most common infections that can occur. And so yeah, those are the things that will come in the communication station. And the second one, as I mentioned, was the phone call station. So in this, what happens? This here you get a preparatory station. That means you get 10 minutes before the actual station to prepare for the station. Okay, so here you enter a room. You're alone, and you have the patient file with you. You have all the details of the patient, right from history, how his progression is going, all the investigations, the IO chart, the daily notes of the patient, if he's undergone any procedure, all that notes will be there. It will be kind of scattered. It won't be in the same order because if you're the first guy entering the stations, you're lucky. But if you are going into station after somebody has already gone, so most likely they would have, messed up with the order of the papers. At least that was the case with me, and so I had to kind of go through the papers and try to understand what exactly the case is. But anyway, on the station, on the question stem, they would have mentioned this is a case of so and so, and now you have to refer the patient, or rather take a specialist opinion regarding certain aspect of the patient, so you know why you have to why you are calling a specialist and call over the phone asking a senior consultant regarding something. Okay, so that much will be clear, so that based on that, using that information, you will go through the file quickly, because it's a quite big file. So you go through the file quickly, and then you will be given a paper and a pen, so you just jot down things that you feel or think are important. Okay, so once 10 minutes are up, your bell sorry, 9 minutes are up inside, your bell rings, and then you go to your next station. That's the actual phone call station. So once you go inside, there will be a phone in front of you. You just have to press redial. So once you press the redial button, it will get connected to the examiner who is sitting in some other room in the same area, and then he will start asking what is the matter. So again, you introduce, I'm so and so doctor working in so and so hospital. I've called. Am I speaking to doctor whatever John it is? If it's John, you just say Dr. John, senior gastroenterologist or nephrologist from so and so hospital. He says yes, that is me. So once you confirm whom you're talking to, whether you're talking to the right person, then you say, okay, I've called regarding the reference for the particular patient by name so and so. He's a post-operative case, and his urine output is only 500 ml or 400 ml over the past 24 hours. I have called you to ask regarding the further management of the patient, or whatever it is. Okay, so whatever that you mentioned on the stem outside. So then the person on the call, the examiner will ask you certain questions. It will be like, okay, what do you think? How do you think are the investigation? What do you think the IO profile is, input output profile of the patient is? So what do you think it is? Then he's kind of extracting the information from you. Then you will start telling that that information will start giving. So that's why having that paper and pen that on which you have scribbled information is important, because that will be useful at this point of time. That he might ask something that you might not have noted down. So you'll, again, there will be file in the phone call station also, where you can actually go back and forth and look and tell. But it does not seem quite good on the phone when you're talking to a consultant, going back and forth for the information. Even if you do not know, if you go back and forth, no problem. They will wait for a few seconds. You say, okay, can you hold on? I'm just going through the file. Okay, you can say that, and you can tell the value if at all you've not noted down, or if you thought it was not important in the during your preparatory phase. So all of that, and then he'll help you come or rather arrive at the diagnosis. Then he will give you the advice also. Then he'll be like, okay, what do you think should be your management? For me, it was post-operative hypovolemia, because of uh, the fluid fungus. So basically, the input was less, so hence the patient's output was also low. So somehow we arrived at the diagnosis, and then he said, "What do you what do you think you should do?" And I was like, "Okay, you have to supplement, rather, sorry, give maintenance fluid at blah blah rate. This is the fluid." And he says, "Okay, fine, go ahead. This is what you're supposed to do." That's how your phone call ends. And you say thank you, and you cut the call. Okay. So that is how the phone call station goes. Everybody gets a phone call station, so make sure you practice this pretty well. And that's the overview of our knowledge station and the skill station that I have just told from my experience and from what I have heard from people who have undergone this exam.